Vasu? Good evening, Smriti.
Good evening, sir.
Vasu, you are there?
Sir, Mehul here.
Acha, you and Mehul. So Vasu is not there?
No, he is not connected right now.
Okay.
Okay. So, can we start now, sir?
Good evening, sir.
I think so 8:35 is there. We can start because the lecture is too long.
Vasu, you are there? Vasu? Sir, Mehul here.
Acha, you and Mehul. So Vasu is not there?
No, he is not connected right now.
Okay.
Okay. So can we start now, sir?
Good evening, sir.
I think so.
Okay, sir. So good evening, doctors. So I, Mehul Doradia from Corona Remedies Private Limited, welcome you on the live webinar Core Connect on Wings Fertility Conclave, which is initiated by Wings IVF Center and associated with the Corona Remedies Private Limited. So, first of all, I welcome Dr. Smriti Sparsh, who is the Chief Consultant of Wings IVF Patna. And earlier, she was an assistant professor in Netaji Subhash Medical College and Hospital, Bihta. And she is a joint secretary of Boxcon 2022 and also chairperson of endoscopy committee. She achieved lots of awards like CL Javeri Award, as well as Youth Times Youth Icon Award and Ishar Youth Icon also. And right now, she is an active member of FOXI, IFS, IMA, Ishar, and BOGS also. And she has a she is a very much expertise in infertility and laparoscopy also. So I welcome Dr. Smriti Sparsh on this live platform and live webinar. So requesting you to please continue and welcome.
Thank you, Mehulji, and very good evening to sir and to Corona Remedies for giving us the opportunity and the pleasure to introduce our CMD, Dr. Jayesh Amin sir. Anything that is said in the honor of our CMD would be less, but a little subtle introduction for everybody would do the good and justice. So Dr. Jayesh Amin, Clinical Director of the Wings IVF Group of Hospital. Sir is also the Secretary of Gujarat Chapter Indian Fertility Society. Sir's main areas of interest are in troubleshooting the complex infertility cases, recurrent IVF failure cases, application of the latest technologies in the field of IVF, and the role of genetics in the IVF treatment. To various achievements that Sir has in his with him are the national and international. He has been the national and international faculty at various fertility conferences in India and abroad. He has been awarded with the Times of India IVF Icon for 2018 and 19, was also honored with the Excellence in Infertility Treatments by the then Union Health Minister, Shri J.P. Nadda ji. He has been the Fertility Game Changer West 2019, awarded by the Economic Times. And to Sir's honor and to the credit in the Wings IVF Group of Hospital are 12,000 plus live births through IVF in the past 8 years, with 8,000 plus successful cases of those who have previously had unsuccessful IVF treatments. I welcome you, sir.
Smriti, thank you so much for kind introductions. And as you know that Dr. Smriti is our chief consultant and very experienced IVF specialist at Patna. And I welcome all the delegates from all pan India, and specifically this webinar is basically organized for the Patna Obs and Gynec Society. It's a Zoom meeting where we are going to take a different aspect or basic aspect. So today's is first basic aspect that I'm going to inaugurate, which is physiology in the reproductions. And later on, there are 2 lectures, which is luteal phase, and third is aging and infertility. So which will be taken by our whole team. So let's say something going toward the, I'm just sharing my lecture. Ayush. Just sharing the lecture, 2 minutes. The lecture is visible or not?
Not yet, sir. Yeah, now it has started. It has started now, sir.
Okay. Yes, Ayush, it is visible now. Now I'm making the screen.
Full screen would be better, sir.
Yeah, yeah. Yes, I think so. Everything is okay.
Yes, sir.
Yes. So let's say something. Today we are discussing about the physiology. And when we start about the physiology and reproduction, human reproductions, we always knew, I always have to know something about the embryogenesis of the ovary. So we will ask the question that what will exactly going on, which are the chromosome which is responsible for the development, and which are the part of our embryo which is responsible for the development of the ovary, because this is more important. And this is all about the, as we know that the absence of SRY gene. That means not presence of X, but it is more about the SRY gene, and that will lead to a development of the Mullerian duct. And that Mullerian duct will be developed into uterus, fallopian tube, cervix, and upper 1/3 of the vagina. So I'm talking about the whole genital tract. So first we are focusing on that development of this, except from the ovary. Right now we are coming on the how this ovary is going to be developed, and this is what the about the coelomic epithelium, and by that the germ cell will migrate and forming a ridge, and that ridge, I think so, it will be formed around 10 weeks to 14 weeks. The whole ridge is whole ovary is going to be developed. Now, which are the genetic background of the development of the ovary? Yes, that of course the X chromosome is responsible, and X chromosome inactivation in random in germ cells before their entry into the genital ridge, when the silence X chromosome is then reactivated. So it's all about the X-linked gene which is responsible for the formation of the ovary. Now let's say something about the which are the part of the X chromosome which is responsible. So this is the part of the specifically that Q arm 13 to 21 or Q arm 13 to 27. These are the part. If anything which is occurred to that, if any deletion is there, any damage to that, then yes, we do have a certain things, and that is what we can see something in a fragile X syndrome, that is called premature ovarian failure, where I think so we are having a FMR1 and FMR2 gene mutations. That is location on the XQ27.3 and XQ28. So now you can understand that development is started from the 9 weeks or 14 weeks, the X chromosome is responsible, 21 to 27 Q arm. And that I can like to say something. When you have a POF, you can inquire regarding the development, whether the mutations, the Fragile X syndrome that is called FMR1 and FMR2 gene mutations will be there. Then your ovary is having a premature ovarian failure. So I would like to say that here, that when there is SRY located on the Y chromosome, and if it is absent, look at this red area, that where SRY gene is absent. So there will be no activation of SOX9, but there will be activation of the red area. So it may be RSPO1, WTN4, and FOXL2. And this is basically responsible. So anything mutation on this also, if you have a WTN4 family mutation, if you have a FOXL2 mutation, if you have a RSPO1 mutation, these all will lead to something mutations in the differentiation of the ovary. Now you can understand. So ultimately X chromosome, absence of SRY. So there will be no presence of, no activation of SOX9. And that will be activation of the RSPO1, WTN4 gene and FOXL2. These are the all going to beta catenin gene activations, and ultimately at the end of the day, the ovary formation will be there. So anything here, if there is mutation is also in this family, also we can have a differentiation with defect in the differentiation of the ovary. Another thing that I want to say something about, that whenever the ovary forms, now it will lead to some primordial germ cells. So which are the primordial germ cells? The certain gene you can see something about. Then there will be a differentiations in the ovary specification. So you can see WTN4 and FOXL2 and RSPO1 gene family. And then it will convert into, because of the effect of the estrogen, it will convert into primordial follicle. But again, this primordial follicle, that this whole pathway is also depend on the FOXL2. FOXL2 gene is the specific group of the gene, right? Where the P10 is the inhibitor. So if P10 is a break, if P10 is not there, then there more and more primordial follicle will convert into antral follicle, right? So that's why sometimes people do have a premature ovarian failure, because of the exhaustion of the more and more conversion of the primordial follicle into the antral follicle, and early age their AMH will be lost, right? So when there is a P10 mutations will be there, and there will be a low AMH, we can say, and that exhaustions of the more and more primordial follicle into the pool of the antral follicle, and there will be exhaustions. So this is what we can say, how the genes are, the pathways are responsible for the antral follicle, and then pre-ovulatory follicle will be there. Now let's say something about here also. I'm just showing that migration to germ cell reach to formations and ovulation, right? The formations and ovulation, this was again that how we can say that the antral follicles are gonadotrophin, and pre-antral means pre-antral follicle are gonadotrophin independent, and then they become gonadotrophin dependent at the end of the day. Now this is a very good, beautiful that a picture. By that you can say why we can need certain things, antioxidants for certain days. Why? So what will be the time period which is required from primordial follicle to pre-ovulatory follicle? If you say something around primordial follicle to primary follicle, it will take around 120 to 150 days. And another primary follicle will convert into pre-antral follicle will be 120 days. And this pre-antral follicle will convert into the antral follicle is around 70 days. Now this is more important, that this 60 to 70 days is more important. So it's around 3 months. And that is what we are giving antioxidants, and whatever the treatment we are giving from, I think so, whatever the publications for recruitment of the pre-antral to antral follicle, where we are giving androgen, DHEA, everything, the publications will be around 21 to 61 days. Why? Because the physiology support. Because of the physiology support. And this antral follicle, then we know that around 14 days, by with the effect of the FSH and LH, it will convert into the pre-ovulatory, and then ovulation will occur. So what we learn of the ovary, that X is important. We learn that Y gene inactivation, SRY inactivation is important. We learn that there are certain gene WTN4 and FOXL2 and RSOP1 is important. And we learn to that if there is an elevated PI3K signaling, that means it will increase the antral follicle to the ovulatory follicle will be there. So primarily to antral follicle will be there if there is a elevations. Now let's say something about after the birth. So after the birth, what happened? So after the birth, I think so at around gestation, around 20th week, we have 7 million follicles, primordial follicle will be there. 7 million, 7 into 10 raised to 6. At birth, it is around 1 million. At puberty, it is around 3 lakh. And around this 3 lakh, I think so, there will be lot of atresia, follicular atresia will occur, but 400 to 500 follicle will enter and they will get into the ovulations. So basically we are interested in this 400 to 500 follicle, which is responsible for the ovulations. And the last part that I want to say something, at the end of the menopause, even around 1000, even the menopause, in the surrounding layer of the ovary, there are 1000 follicles are there. And that is called the dormant follicle or sleeping follicle that you can activate by the certain growth factor or stem cell. And that the future, I think so, in the very extremely low AMH, that how we can increase this dormant follicle pool into the antral follicle by activations, either it is in vivo or in vitro. So that is why we can deal the patients with the low AMH, or we can say deal the patient with the premature ovarian failure. And how the ovarian aging will be there. And this is what I already said, that after 32 years of the age, the decline is going to be started. So up to Indian female everywhere 32, and it will be declined up to 42 to 45, and that will end up with the into the menopause. So we need to learn something like that, that as age increasing, the number of antral follicle decreasing, as age increasing, the quality of egg to convert into the healthy embryo will be decreasing. And that is why we have a less chance of the pregnancy when age is increasing. This is something about that. Sometimes we tell something why this female in the today's era do have a early adrenarche or menarche. And this is all about the healthy food diet, appetite regulating hormones, energy. We are taking all about the high energy intake diet. And that's why we have an early menarche, which was observed with the comparison. I think so in 9 years and 10 years now, female do have a menarche in the early part because of this healthy lifestyle. So 5 days after birth, gonadotrophin level rise sharply. Gonadotrophin, that means FSH and LH after the birth. But after then, there is a transient phase for 4 years. So there will be step down phase, right? So FSH and LH, then it will be not going to be increased. So that is called early elevations of the FSH, LH, even during immediate after birth. It is very short, but then followed by there will be sleeping phase will be there up to 4 years. And let's see something about to all the students, those who are seeing that there will be axis, which is more important. I am always saying that those who are having a deep knowledge of HPO axis, that is called hypothalamus pituitary ovarian axis. And that is the important, I think so, being a infertility specialist, I think so, knowing this all physiology, it will clear all idea of stimulation protocol of IVF. So there is a hypothalamus and there is the anterior part of the pituitary gland, and they will connect it. Hypothalamus and pituitary both are connected with the posterior pituitary and anterior pituitary, which will be collected with systemic artery. So this is the circulations where they convert certain hormone will be there. Now let me tell you something about that, exactly what going on. I'm telling something which was not known by you. In hypothalamus, today's it was known that in hypothalamus there are neurons, and that is called GnRH neurons. So this GnRH neuron, which is situated in from preoptic area, certain other neurons, which is called kiss-peptin neurons, neurokine B and dynorphin. So this is called KNDY, and that is, if you are going to have a mutation of kisspeptin gene, then again there is a problem of releasing of the GnRH, because GnRH releasing hormone is going to be released by the activation of the kisspeptin and neurokine B and dynorphin. If this neuron, so whatever the factors which augment the neurokine B with augment the kisspeptin gene activity, they will have a positive effect on the GnRH neurons, and this GnRH neurons will release a GnRH hormone, and that will go to the circulation, and that will go to the circulation through circulation to the anterior part of the pituitary. So coming to that, here you can see very good diagram. This is a kisspeptin positive. So if you are having a obese, if you are getting a good food and fat, very healthy diet which contain calories, everything, which having a positive feedback mechanism. But that positive feedback mechanism, which effect on the first kisspeptin and neurokine B and all dynorphin, that will going to be effect on the GnRH neuron, and GnRH neuron, GnRH secretion will be effect on the anterior pituitary, and anterior pituitary which effect on the FSH and LH. So why I'm telling all this thing, that whatever the receptor polymorphism, receptor mutation of the kisspeptin, and today's people are by decree, because GnRH pulse is correlated with the LH pulse, not FSH pulse. So it is correlated with the FSH LH pulse, and it's very, very frequent pulse. FSH is a long pulse, but it is not a frequent pulse. So let me tell you something. I want to reduce my LH pulse in PCO. Previous future will be there. I will reduce or I will have something to act on the kisspeptin gene. Then my LH pulse is going to reduce, and my LH pulse is going to reduce. Then I do have a less effective PCO formations in the future. That is what I think. So future therapy will be there, that we can reduce the effect of the kisspeptin. So let me tell you, insulin, AMH, and ghrelin, so GABA, this is having effect on the whole positive effect on the KDN complex, which is released again the FSH and LH from the anterior pituitary. So this all thing, I think, so this is all conclusion that how FSH and LH. Now let me start with it is a new breaking. So we need to understand that why we are having ovulations, and what is this FSH and LH doing on, what is exactly going on in the body. If you see something about that, this figure is showing that some energy sensing, some fetal stress, some adipose tissue, some endocrine disruptors, some adrenarche, the epigenetics, right? Psychological stress, gastrointestinal axis. And this all factor, do you believe that this all factor will be effective, whether it is positive or negative effect on the KDNY or the other pathway? And that's why we do have something. If you have anorexia, if you have appetite loss, then we can have amenorrhea. So these all are related. The nutritions, the energy intake, these all are related. And if you are taking a more stress, even I think so, IUGR fetus do have an effect on the ovary also. Right. So this is what we can say about the effect of the 20 genes which is responsible, and the surrounding effect will be there for the formation of the FSH and LH. So which are these FSH and LH? That TSH, FSH and LH anterior pituitary is a glycoprotein family. So let's say something which is the hierarchy control, as we know that something hierarchy is always there in body. This is the hierarchy, that is the input in the hypothalamus, then it goes to anterior pituitary, and then it goes to endocrine gland. I think so that will be a ovarian. There are some the positive feedback mechanism and negative feedback mechanism. And anterior pituitary, I already say that FSH, LH, these are the hormone which is TSH, which is secreted by the anterior pituitary will be there. What exactly the break in the woman? And that is called a break. It is called menarche or adrenarche. These are the two break where, so there is a silent ovary and they are entered, suddenly they are entered at the 9th year. This is called puberty. So we can say puberty is defined as the period of first becoming capable of reproducing, because we are discussing about the reproduction is marked by maturation of the genital organs, development of the secondary sexual characters, accelerations of the linear growth velocity. So it's all about the adrenarche. First, adrenarche in the early part. So you have a pubic hair, you have an axillary hair, and followed by there is a maturation of HPO axis, so that you have a menstruation. So first there is a secondary sexual character development, maybe breast development, maybe axillary hair development, maybe there is a pubic hair development, followed by there will be a menarche. So this is what I can say, that precocious means if it is coming less than 8 years, that is called is precocious puberty. And I think so average onset of the puberty is 11 to 12 years, and if it is less than 16, more than 16 years, then it is considered as a delayed puberty will be there. And here you can say something how we can define that early and precocious puberty will be there. These are the different hormone changes will be there. And I will like to say that now whenever the HPO axis is going to be, now the point to be noted in your mind is that GnRH releasing hormone is coincide with the LH pulse, not with the FSH pulse. So that's why as GnRH is frequency increasing, at the LH pulse is going to increase. And how this is something I can say during birth, then 6 months, 10 to 14 years. And after 10 to 14 years, you can say something how this LH pulse is increasing. So this which say something about the LH secretion pattern as far as concerned the secretion by the changes in which was shown in the GnRH releasing hormone. You can easily say that how LH and FSH. So more LH frequent amplitude you can see in the during the 14 years to 15 years will be there. So now I'm coming to the our reproductions. So how FSH and LH. Now this FSH and LH will affect on the receptor which will be find out on the granular cell. So LH receptor is on the theca cell, and what it happened that LH is effect on the theca cell, so they will increase the CAMP pathway, they will increase the testosterone formation, androstenedione. So ultimately LH is responsible for the hyperandrogenemia in the initial intra-ovarian hyperandrogenemia. Is it required? Yes, it is required for the sensitivity of the FSH. And that is then FSH binding toward the granular cell, it will increase the FSH binding. So the other second point should be noted that subandrogenous LH is required. What is the normal value of subandrogenous LH level is 1.225. Only 1% of the LH will effect on the theca cell, and with the effect of the hyperandrogenemia, FSH will act. So now what we learned about that, the procedure which is called as a recruitment, because recruitment is one of the most important part. Recruitment, selection, dominant, and ovulation. These are the 4 things which will occur. Now how this recruitment occur, it is because of the endogenous LH. So endogenous LH is required for the recruitment. And look at see something, because whenever this FSH pulse, so whatever the release of the FSH pulse, which is the effect of the GnRH release, and when it cross the threshold, now different follicles do have a different threshold. So the follicle which is respond to that FSH threshold, which going to be increased and which going to be effect. And why? Because of the subendogenous LH. So the period where the FSH passes the window, passes the threshold, and if it is lasting a longer time, then it is called as a FSH window. So now it is very important that if you are increasing FSH dose, so ultimately that threshold will cover a lot of follicle. So it will recruit more follicle. And if you increase the window of the FSH, the time period of boosting the FSH in the body, then again the continuous cycling, continuous follicle which are growing, they will going to recruit. So more recruitment which will be visible specifically in the this window period. So I can say something, increasing dose of the FSH and increasing the window period, and also the presence of LH, subendogenous LH, which is responsible for the more and more recruitment of the follicle will be there. So what is the role of the LH? I will always say LH is a very crucial hormone. I am again saying that it is crucial, but not only it's a notorious hormone. So why crucial? Look at the physiology which is required. Because on the effect of the theca cell, they will increase the androgens. So they are responsible for the recruitment with the effect of the FSH. Now, Let me tell you, after 8 day, my next slide, with after 8th day or 10 mm of the follicle, again, granulosa cell develop the receptor for LH also. So then what happened? That FSH and LH synergistically acting on the two-cell theory and increasing more and more estrogen. So LH is also required for the secretion of the more estrogen, for the formation of the bigger follicle, and LH is also required because after when estrogen reaches around 200 picogram, it is having a positive feedback mechanism on the LH, not FSH. They will reduce the FSH. So as estrogen is increasing, the negative estrogen increasing, the inhibin B and estrogen, which are having a negative feedback mechanism, even so it leads to reduced FSH. And there is a reduced FSH, so other follicle will not going to be produce any formation. So there will be follicle atresia will be there and only one dominant follicle. And when it reaches around whatever the size where LH surges occur at 200 picogram for 48 to 54 hours in the body, then there is ovulation. So LH is responsible for the ovulation, that is called resumption of the meiosis. M1 oocyte is converted into the M2 oocyte. And third thing, LH is responsible for the cell survival. So it's all about the quality of the hormone. It's all about the quality of the embryo, which is always formed because of the presence of the LH. So whenever the LH, so if you don't have endogenous LH, less, now let's say something less than 1 is a cutoff value, then there is a problem. So find out whenever the endogenous LH is less than 1, especially in the advanced maternal age. So LH is not inside, so it is an ineffective, right? And second is LH is defective. That means LH is there inside, but the receptor is having a problem. So LH is not going to bind. Even you are having a polycystic ovary, your LH is very higher, but the receptor is not there, means it is a polymorphism. So LH will not bind. So you need to add exogenous LH in LH polymorphism. And that is why today's people are adding LH polymorphism or empirically LH to for recruitment in the follicular phase. But I again say LH is required. It's a crucial hormone for the also the increase the secretion of the progesterone. It is also responsible for the implantation milieu. It will increase the estrogen and progesterone, but high estrogen and less progesterone. That is what LH will do. So naturally, it will also provide implantation milieu. So 4 activities which is responsible for LH. But mind well, it is a notorious. When you are interested in stimulation, if you are adding LH, then you should be very cautious that you will not cross the threshold. And this is what I want to say, that when you cross the threshold of the LH is more than 5, then again, the hyperandrogen, so more testosterone. So ultimately it is environment of polycystic ovary. So there will be maturation arrest and more FSH is required to stimulate the ovary. So I will like to say something at that LH is a notorious. So not to add LH is always beneficial rather than to add LH. And if you add LH, then please add LH cautiously. Looking to that this is LH, where LH receptor. I already say that LH receptor will be always visible whenever the follicle will grow around more than 10 mm. Right? Then there is a follicle. So during this 10 mm, then what happened? So around 8th day of the menstrual cycle, they develop the LH receptor, and that LH and FSH then will augment. This is the two-cell theory. That is what I'm saying. What LH will do? It increase the FSH receptor expression. It acts synergistically. IGF-1 increase, so increase the size of the follicle. And it will always increase the estrogen formations from the follicle. So it's all about the growing of the follicle, where later on of the growing of the follicle, LH is also required. And this in the natural cycle, if you see something that subendogenous LH is always more than 1.2. So that's why we say that less than 1.2 subendogenous LH is required, adding LH will be there. And I would like to say something about the LH. So LH is reducing in the age. And that's why if you have a mitochondrial function is impaired in the age, granular cell number are reduced, oxidative stress increase, aneuploidy rates increase. So this is all the effect of the FSH age. And that's why you require more LH because of the cell survival activity, because of the less number of the granular cell. These all will always help it out that when the age is higher, you require LH. When you have a substitute of LH, that SCG, let's say add something HMG where it is having SCG. Only the side effect SCG, it's a prolonged. So the binding activity, it is SCG is around 7 days. We can say half-life is SCG 6 to 8 hours. Again, it is 1 hour of LH and they will binding around 7 days, and 6 to 8 IU LH is equal to 1 IU SCG will be there. This is what these are the different pathway where LH will act on the cell survival. So LH is always recombinant, LH is always, rather than SCG, it is having a cell survival activity. Let's start something about, before I will start the clomiphene citrate and letrozole. This is the history. These are the legends, those who are in the life. They have the first that they first picture of, means they find out the first picture of the sperm cell, then the first vaginal inseminations, then there will be a first IUI will be there, and there will be a first IVF birth, which is our legend is Bob Edward will be there. So these are the things which was developed, and later on, I think so in today's era. So as the evidence develop in today's era, we are shifting about that. When we want to stimulate the ovary, how can we differentiate the patients, that which type of the patients? I think so there is a paradigm of age when nothing is there. And in between, there is a paradigm where age and FSH. So we are saying that whenever the FSH is higher, more than 9, and we'll consider as a poor responder, less number of the follicle. But I think so after 2012 to 2000, this is the 21, 23, we are always expecting age is the individual, the quality factor, where the quantity factor will be determined by the AMH and AFC. And I still believe that AFC will be the gold standard rather than AMH. I still not believe in AMH more. I still believe more AFC, whatever the data says. So in my practice, I will do always AFC. AMH I will do only in the certain region to counsel the patient, to explain the patients before that. And today's, I think so we are all shifted, and we are all thinking about the sensitivity. It's not about the recruitment. It's not about the quantity parameters. It's about the sensitivity, and that is called genetic polymorphism. So I do have my publication, which is going to sooner publish about the genetic polymorphism, role of genetic polymorphism, specifically for the FSH and LS sensitivity. So how we are going to differentiate? And as we do sonography, and there will be last, we all people are knowing that if a sonography shows more than 20 antral follicle or 24 antral follicle, it's PCO. It's not only antral follicle, it's all about the volume of the ovary. It's all about the volume, means it's about the stroma against follicle, the ratio, which is more than 0.74. Then again, it is called as a polycystic ovary. And when you have a normal ovary, it is called 10 to 20 antral follicle. And when you have a less than 5, so less than 10, anything less than 10 antral follicle in both ovary, we are saying it is a poor responder. And let me aware you that we still not believe in the younger age at any AMH. You can have antral follicle variations, and you can have a cryoaccumulation. You can give their own egg pregnancy in a younger age if it is not associated with a bilateral gonads or very small volume of the ovary. The major cause of the subfertility, I think, so we know that unexplained infertility is major. There are region to region, but we can say something around unexplained and ovarian dysfunction, which is the major cause. While say something tubal factor in the region. So in my region, if you ask me in Gujarat, then I don't think so it is more than 3 to 5%. But when you go in the metro city, it is lesser. But when you go in the periphery, when hygiene is the hygiene and nutrition and the literacy rate is poor, then the tubal factor is almost, so overall tubal factor is 14%. And male factor is as good as what about say 50% will be male factor will be there. And let's say something about what oral drugs. Now we want to, so we know the definition of the infertility. The couple, those who are trying for pregnancy for 1 year without any using contraceptions when the age is less than 35. If it is age is more than 35, then 6 months, less than 6 months. So we can say it's infertility. So these infertility couples, we know that the natural fecundity ratio is not more than 20%. In a first year of the married life. In the second year of the married life, it is only 7 to 10%. In the third year of the married life, it is only 1 to 3%. So as active married life increasing, I think so the fecundity ratio will be reduced. And at what point time when couple can go to the gynecologist that after 1 year? And at what point time that should we start something oral ovulation? I think so only when patient is anovulations. So if patient is having an ovulations or patient is having a long standing that might be super ovulation, maybe super ovulation. So not only ovulations, certain patients might require super ovulations. So when we can go by ovulations and super ovulations, and we can do certain treatments. And we do have a two molecule, I think so. The old and gold molecule is the clomiphene citrate. And on the left side of you, this is the action of the clomiphene citrate, the mechanism that they are occupying the receptor. So occupying the receptor on the anterior pituitary. So what happened that the estrogen negative feedback mechanism will not go on. So ultimately they will release more and more FSH, less LH, and that's why we have a stimulation. But if you ask me that the same thing that on the next side, right side, which is called aromatase inhibitors. So ultimately they will not convert more and more testosterone to estrogen. And that's why the negative feedback mechanism is not going act, and that will increase. So it's not potent as good as clomiphene citrate. Letrozole is a weak compared to the CC. Let's see something about CC. I already say something how they are going to be talk. So when we talk about the clomiphene citrate and letrozole, what is the question arise in my mind that it's end of an era of clomiphene citrate? I will say it's difficult to answer, but we can use clomiphene citrate. Still, it will be a treatment of old protocol. But now, what is the evidence that should it replace by? So this is the publication which are in favor later on. So until the publication, this is a very past. I think so. It is in 2005. We are talking about 2005. Where we are struggling with the molecule of letrozole, especially in the foreign country. It is basically because of the side effect. They say something congenital defect in the fetus, and that's why they are struggling. And we have a ban immediately of the letrozole, and that's why we are using clomiphene citrate. I don't think so that we are worried about any, but it's both side effects are the same. And I know that what exactly we are doing that clomiphene citrate, we are always starting in 50 milligram in PCOS patient, 100 milligram in normal ovulatory patients. But when we give to any PCOS patients 50 milligram day 5 to day 9, and suppose we don't find out anything on day 2, day 14, then we can give 100 milligram for 5 days. Again, we cannot find out after 1 week, no follicle will be there. And if we give 150, and there is no follicle, it is called a PCO. So up to 200 milligram, if there is no ovulation, then I think so. If it is continue for 3 cycles, it is considered as a clomiphene resistance PCOs will be there, or clomiphene resistance ovary will be there. Then we need to choose around the second, and I think so later on, because the ban, because all the publication which are favor, and letrozole, which is the molecule which is coming at 2.5, it's aromatase inhibitor. So these are the different way that 2.5, 5 milligram, 7.5, 10 milligram. These are the different doses available. Now, what about the stir-up protocol of the stir-up? That means we need to give 2.5 milligram for 5 days, ultrasound 5 days, 5 to 7 days. So on 10th day, and even it is not effective, then we can another letrozole, we can give 5 milligram for 5 days. So increasing stir-up protocol, I think so. Right, it will increase later on 5 days. It will increase the follicular recruitment compared to the clomiphene citrate. So this is again in the polycystic ovary. This is called stir-up protocol. Now another thing is extended letrozole therapy. So extended letrozole therapy, short letrozole group is had a 5 milligram of letrozole daily, only 5 days. But this is all about the 2.5 milligram for 10 days. So this is the first stir-up. This is the extended letrozole protocol, the 2.5 milligram for 10 days, especially in the polycystic ovary. Then clomiphene citrate resistance will be there, right? So you can use, I already said 2.5 milligram, 5 milligram, and 7.5 milligram for 5 days. If it is not, again in the other polycystic ovary, when there is a resistance for 5 milligram, then you can go by 2.5 milligram for 10 days. So the long letrozole 10 days can produce more mature follicle and subsequently more pregnancy than the short letrozole therapy. This is the publication that what I want to say, which was published in the Fertility. Sterility. Now again, this is the UOG Journal Club, January 2018, the effect of clomiphene cited on. So we know that there is anti-estrogenic effect. And in this, they had shown that letrozole is not having, so it's all about the 20 studies, the meta-analysis, which shows that not only ongoing pregnancy, clinical pregnancy, live birth rate, but the most important, this is all about the favors that CC, the letrozole is favors. These all meta-analysis. At the end of the day, we can say that the endometrial thickness, ovulation, pregnancy, and live birth rate women who group 2 in ovulatory disorders. So these are about the ovulatory disorders, not anovulatory. Anovulatory we already says. And what about the anovulation? And this is about the PCD patient, that phenotype A, B, C, D. These are the different phenotype. You can say something. And there is a publication that phenotype 1, 2, 3, 4. And they said that if you phenotype 1, then they will affect. I think so. They will more affect. They required. Phenotype 1 is required more and more. They required increase, so they required 7.5 milligram high dose. And phenotype 4, so phenotype A and phenotype D both are required the high dose 7.5 milligram. But if you see have a phenotype B and phenotype C, then they don't require a high dose. They will always respond to 5 milligram. So we need to find out that which type of the phenotype of the I already say that phenotype A, that means you can easily understand what is phenotype A by understanding about the PCOS. If it is phenotype B, so phenotype A and phenotype D both are required 7.5 milligram higher dose of the, rather than phenotype B and C will not require. And this is again the repetition theory that what I'm saying, that high dose is required to get the pregnancy, especially if you use in phenotype A and D 7.5 milligram or 10 milligram, they will increase the pregnancy rate compared to the phenotype B and phenotype C. This is a good again. Now another meta-analysis, now later down, that then should we shift our practice to clomiphene cited to letrozole? The answer is yes. And this is a recent meta-analysis which is including 10 randomized controlled trial, which is not only say ovulation induction, rate of clinical pregnancy, everything is in favor. So letrozole now be considered as a first line of the treatment, not only on the anovulatory but ovulatory. So if you are having an anovulation or ovulatory cycle, in both conditions, letrozole will be considered by this meta-analysis which was published. It is a first line of the treatment. And what are the advantage over clomiphene citrate? It's all about, we know that monofollicular enlargement, decreased multiple pregnancy rate, and we know that anti-estrogenic effect, right? So these are the 3 advantage. Let's say something about that. We have a unexplained infertility. Now, this is what we can say, that should we, whenever the Honor score, if you know about the Honor score, it's all about the duration, primary infertility, duration of the married life, and the semen factor. By that, we can consider the Honor score. Of course, if you are having the second primary infertility more than 3 years, that Honor score is very higher. If you are having a primary infertility, your Honor score is very higher. If your semen report is low normal report, the Honor score is very high. But if it is your Honor score, it is, so ultimately, if you are having a between 1 to 3 years of the active married life and your semen report is good, in that condition, this is the study that expected management is equally effective than the IUI. So you can, if the age is younger, so less than 30, this is also again in Honor score. If your age is less than 25 to 30, if your active married life is less than 3 years, if your male factor is toward higher side, so ultimately Honor score is less than 30%. If it is less than 30% in this condition, I think so expected management will be as good as IUI, right? So you can advise the patient, those patients who are still not want to, if cervical factor is not there, yes, again, I will like to say something about, rather than aggressive to go by IU and IVF, it is always better that expected management will work. So expected management for 6 months is fine. That is what this all studies are saying. Now, another thing is that these are the different comparative effectiveness of 9 ovulation induction therapies. So we have a 9 induction ovulation therapy. We know that we will have a CC, we will have a letrozole, we will have a metformin, we have a CC plus letrozole, metformin, we will have a letrozole plus metformin, we will have a bilateral ovarian drilling. We have a unilateral laparoscopic ovarian drilling. We have a CC plus HMG. We have a HMG plus letrozole. These are the 9 protocol that, and what it says about the 9 protocol, the higher success rate in IUI, which was observed always in the gonadotrophin. It is always in the gonadotrophin. So gonadotrophin will be the better choice when you are really starting. These are the different live birth rate which was observed. But let me tell you something about now question that, okay, we know now that what are the protocol of the clomiphene citrate, what are the protocol of the letrozole. Now, what is the optimal follicular size? So what is the optimal follicular size for CC and letrozole? And this is a very good publication. 1,775 patients undergoing IUI cycles were studied. And if you see, this is all our the letrozole or clomiphene citrate induced. And if you see here that when you have to see, I am always going to be giving a trigger when this lining is around 8 to 9 or 10 to 11. So when I say something 9 to 10 to 11, then your follicular size, if you see something, pregnancy rate will be more observed when the follicle size is around always more than 22. And that is what I want to say something about, that you can push your follicle size in 20 to 23 mm also, especially in the CC induced and letrozole cycle. So what will be the timing of SCG? If you want to give, it is always after 22 mm, where you are reaching the size of around at least around 8 to 9 mm, and then you can go ahead with the giving the SCG. So this is a beautiful publication that how it will differ from the gonadotrophin. So giving SCG is not harmful in natural or oral stimulated cycle. It's all about the frequency of the intercourse and possibility, no significant difference in the pregnancy rate, increase the cost only, reduce the number of visit and follicular. So in the foreign country, because we cannot say something about multiple visit. So reduce the visit also, we can go ahead by the SCG. And follicular diameter, that is 23 to 24 mm, which is CC. So you will ask something, what about the letrozole? Letrozole is also same. So it's a higher size compared to the gonadotrophin. Now, what about the different protocol of the letrozole? We already say that we can give 2.5 milligram for 5 days. We can give 2.5 milligram extended protocol, that is 10 days. We can give a 3 to 7 days, 2.5 milligram first cycle. If it is not effective, then second cycle is 5 milligram. If it's not effective, then 7.5 milligram. And I think so that there is the option 2 is the step-up protocol. Step-up protocol, that is what I am doing. Previously, I'm thinking it was not published, but today, because I'm making a lecture, I come to know that it is already published. And that is what I would like to say, that you are increasing dose. So 2.5, 5 milligram, 7.5 and 10 milligrams. So it's a 1, 2, 3, 4. It is increasing dose will be there. These are the different publications which are in favor of letrozole. So again, we can say letrozole. Cochrane is also again in favor of letrozole. Clomiphene citrate and metformin appear to be less effective for live birth rate than letrozole. Letrozole will be the effective. We are little bit worried about the congenital anomalies, and this is the last publication which was published, which is say no increased risk of major congenital anomalies. Human reproduction, this is again another publication which is say no congenital malformations. So fetal safety, we do not show any statistical difference, which all this publication, there is a fetal safety will be there with the using of the letrozole. So use letrozole. Now coming to the IUI, what is IUI? So it's a fertility treatment that involves placing the sperm. So you are placing the sperm inside the intrauterine cavity when there is ovulation. So let's say something, how can we select? See, everything is based then. Your selection is so important. If you don't select, the patient selection is more important. But here it's not only patient selection. It's all about the production because oocyte quality. It's all about the monitoring because of the triggering. It's all about the endometrium because embryo should have to implant synchronization. It's all about the semen preparations. It's all about the non-touch technique, less damage to the lower genital tract, and it's all about the support which what we want to give. Let's say something about here, which are the or few facts while beginning the choose your patient. So what patient you will choose? I think so in the era I will choose anovulatory dysfunction, mild to moderate anovulatory dysfunctions, unexplained infertility, still, whatever the ASHRAE data say, I still feel that in unexplained infertility, IUI will be the first line of the treatment if duration of infertility is around 3 to 5 years. But it crosses 5 years. If age is crosses 5 years, I will not use. 35 years, I will not use IUI. So most effective for unexplained infertility, mild, moderate, and ovulatory dysfunction. And I will like to say that another is mild endometriosis, and third is moderate count reduce. So post-wash motile count is more than 5 billion, but I like to say count between 10 to 15 million, or maybe low normal volume of the count of the male where IUI is more effective. But if it is related to with the infection, tubal factor, then I will again say that will be a worse selections. And I always say that age, younger group, I will use always 25 to 30. And yes, obesity is always detrimental for anything about the natural natural opt is required. These are different part of the, so I think so gonadotropin IUI is always good. I say per oocyte conversion ratio into the healthy embryo in 25 to 30 years, it's around 8 to 9%. So if you have a two follicle, then your success rate will be not going beyond clinical pregnancy rate will not be on 15. That's why it is 15 to 16%. But when you talk about the live birth rate, it will not around more than 9%. So never talk more than 9% of the live birth rate, 10%. Average live birth rate of 3 IUI in a good prognosis will not cross more than 25%. That is what I can say. So don't use something IUI repeatedly. And what are my base patient selection? Again, I say, yes, donor IUI, unexplained, mild endometriosis, mild to moderate ovulatory dysfunctions, and erectile dysfunctions. And male infertility, I still prefer more IVF, but when the count is low normal, then I can use as a IUI. Again, how can I use? My patient should be younger, my endometrium should be more than 8 mm, it should be, my reserve is good, my ET is good, and my sperm quality is good. These are the patients where I think so I can use IUI as a choice of the treatment. Now let's say something ovarian stimulation matters. So should I stimulate only clomiphene? I like to say something stimulate. It's all about the what type of stimulate doesn't matter. You need to recruit the follicle. Even you recruit the follicle 2 or 3 with the CC or letrozole. Yeah, super ovulations occurred more than 2 follicle. It is always helpful. It's all about the recruitment. It's not about the what thing. But gonadotropin, why it is having beneficial? Because it is powerful to recruit more number of the follicle, where letrozole and clomiphene cited 80% they were not powerful to recruit more number of the follicles. So super ovulation will be achieved by the gonadotropin. So I always stimulate the ovary. And let me tell you something about these are the different protocol, that CC with letrozole, yes, then gonadotropin and clomiphene cited letrozole, then gonadotropin. So these are the different protocol will be there, and we should be always worried about, because it's uncontrolled stimulation. So we should be worried about OHSS, especially in the PCOS patient. So what type of treatment? I think so when we use infertility, what we have an expected management, we have a clomiphene cited, we have a super ovulation with IUI, and then we can have IVF. What is my aim? So if those who are having a 1 follicle, why should I have only 1 follicle? I can say it will going to get more results. So minimum 2, but maximum 4. We should be always worried about multiple pregnancy in the Europe era, but in India era, I think so people love to go for twin pregnancy. I can understand our future is single embryo transfer, but still I don't think so 90% population in India, they will always say they'll mange more. So that's why they always go by a twin pregnancy when we are transferring embryo. So we should always worried about the second part is more important in PCO is no OHSS. So how can I start? See, let me something which people are saying about the step-up protocol. Would you still stimulate in a step-up protocol? Is it really practically step-up protocol or step-down protocol will exist? I will say no. I will say soft protocol. And in the era of IVF, I don't shift aggressive protocol. I can understand your aggressive protocol will give more results. But when patient is not ready for IVF, they don't have a money for IVF, then I will shift on aggressive protocol. If patient is have a money for IVF, psychologically and financially ready patient, I don't use aggressive protocol, but I will use only soft protocol in the era of IVF. Because I do have a IVF support. But in the periphery, when patients are poor, patients are coming from very distance, they don't want to travel. in the cities. And these are the type of the patient, they want something very cheap, easy, available at their corner of house, and that is only IUI. And that is what still IUI is a very popular treatment in the era of India. So India is still doing more number of the IUI cycle because of the literacy rate, poverty, and not reaching to the center where IVF facilities available. Now about the prevention of multiple pregnancies. So we can say something about that. Should we do CC plus IU and letrozole IUI? Now this is in the past, people are saying that don't do CC plus IUI and letrozole per IU. I still recommended that now, specifically when you are dealing with the patient. Yes, I can start with the mild stimulation, and mild stimulation is always CC and letrozole. And this is the study which is opening our eyes that CC and letrozole are one of the good treatment when Honor score is more than 30. So let me tell you something. When your active marriage life is more than 3 years, you are still in 30 years age, your mild male factor is there. So these are the group of the patients where still gonadotropin is not required, where I still go by the CC and letrozole and do I. This is the study which say that we are not shifting on the gonadotropin, but giving CC and letrozole, which giving the same means it from expected management to IUI. I think so. Rather than expected management, CC and IUI and letrozole and IUI will be more effective. Will be there. So this is what about the whole study. They assigned IVF SET group 2,201 patient. They have a IUI with COH group and 207 patient. And later on, if you see something about the IUI and control over in hyperstimulation, they have a 6 point. Let me tell you something about after 2 cycle. So total number of fresh live birth rate. So if you see something about the live birth rate, it is around equal, which was seen in the patient, those who are having a forwarding toward the IVF. So I still believe that yes, IUI will be the another beyond expected management. IUI, CC and letrozole IUI before using IVF in a certain group of the patient is required. So another point is, let's say something letrozole and gonadotropin protocol. Which are the protocols? Super ovulation. So yes, in IUI we are doing letrozole. Always we are combined with the letrozole, which will reduce the dose of the FSH and HMG. In my protocol, we are using always letrozole 2.5 milligram or 5 milligram, or we can increasing the dose. So there is no doubt about it. A cost effectiveness, yes, you can also do letrozole and alternate day of the gonadotropin 2, 4, 6, 8. This is also cost effectiveness, which is basically we can do, which will also, which is the part of the another letrozole and HMG protocol will be there. But what I am using at my clinic, the soft protocol in IUI, I will be started always 150 alternate day in the normal responder. I will be started 75 IU HMG alternate. So HMG will be my choice of the treatment to reduce the OHSS. So 75 IU HMG and 150 IU HMG will be my first line of the treatment. If something which was not effective, adding letrozole. If something which was not effective, then I will add, if normal responder, and if my follicle count is toward 20, then I will use 37.5. But if my count will toward 10 to 15, then I will use Y58. So it's all about the subjective gut feeling. It's all about the experience that you are using 37.5 to 450. What about the polycystic ovary? I think so still I'm using 75 alternate day HMG is the first line of the treatment. And I can increase the dose. It is called low dose step-up protocol, will be considered as a IUI. So I think so. Which are the problems? Problem is unexplained rupture, maybe hyperstimulations, and maybe too early and too late IUI. So this is hyperstimulation is more important. We haven't seen more premature LS surge, but I haven't used antagonist. But if you have a premature LS surge in the previous cycle, then yes, you can use antagonist. You can call the patient, and these are the patients, those who are having a decreased AMH, decreased ovarian reserve, and 25 days cycle, where you can have to call the patient on 9 days of the stimulations. And whenever the follicle reaches around 14 mm, you can use antagonist in the next cycle to prevent the premature LS surge. I think so. We are using more IVF in this type of the patient. Now, what about the follicle monitoring? I think so. The first principle is more important. Do it yourself. So still there are a lot of people are sending the patients to the gynec radiologist. I've seen in the lot of areas. So I like to say something, all the gynecologists request that do it yourself. I know now the new generation is always doing that themselves. So what about the where we do SCG, 2 to 3 follicles around 18 to 19 mm, endometrium is more than 9 mm, and then I will give SCG and I will do IUI at around 36 to 40 hours of the IUI of SCG. I always stimulate, keeping in mind that AFC, I would never give SCG if a doubt of hyperstimulation. So don't give SCG. I will cancel the cycle, postpone the cycle. I'm not converting my cycle to IVF. I'm not in favor of IVF when I'm converting. Yes, the complication is most probably in today's era, I think so, multiple pregnancy. I don't find out more OHSS. It's all about the strict cancellation criteria. So we'll be finding out more cancellation, then I don't think so. Now, what about the technique to reduce incidence of multiple? It's all about the chronic low dose protocol, use of HMG, use of letrozole. These are the 3 things, and cancellation. So 4 things, very simple. I don't want to make a rectification of all these things. It's all about that HMG. It's all about the low dose of FSH. It's all about the cancellation of the cycle, strict cancellation. Then I think so you prevent the multiple pregnancy, and even the OHSS will be there. These are the ovarian hyperstimulation syndrome. And it's all about, because the SCG is the always culprit. So never give SCG when you find out multiple follicle. This is all about the more than 4 follicle in the PCOS patient, more than another small 8 follicle, surrounding follicle. You can counsel and cancel, or sometimes you can give antagonist also. But I still not give antagonist. I will like to go for a cancellation of the cycle. So my tip is always don't give SCG, cancel the cycle. What about the trigger in IUI? So let's say something about SCG trigger. So this is analysis of 5,610 first IUI natural cycle with donor sperm in China, retrospective. And they say that SCG is always increased clinical pregnancy. What will be the size? What will be the size of let me tell you. Yes, this is the size. What will be the size diameter? So it is always around 18 to 20 mm. Larger than that, then we can gonadotrophin cycle we can give. In my personal practice, I will give around 18 or 17.5 to 18.5 mm, especially in the gonadotrophin cycle. Now, base time to trigger is around 17.5 to 18.5. If you are using a color Doppler, then 3/4 of the follicular circumference. If you are using a 3D, then I think so cumulus ovorus visible. If you are using PSV, presystolic velocity, it is 10 centimeter per second, and rising PSV and steady low RI suggests follicle is close to rupture. So I think so those who are doing, I support, but that plenty of time and good machine, I think so maybe E8 machine is required. And I don't think so everybody is going to be make E8 machines where they are using the perfect PSV for 20 minutes. So I think so size and circumference and the cumulus ovorus, I think so in the era of IVF, this 3 things is fine. But if you are knowing more and if you are optimizing, then PSV will be there. Now, what about the IUI time? Trigger matters. So I already said timing of ovulation and insemination is always 36 to 40 hours after the trigger. Right, 36 to 48 hours after the trigger. Pregnancy rates following. So it's all about that. I think so that here is a 15. So anything around 40 hours after post rupture, it's fine. But when you cross more hours, I think so you should be always do between the 36 to 40 hours. IUI does more the effect of timing of intrauterine insemination in relation to ovulations and the number of insemination. So we have to say something, single IUI is not effective, but in one cycle we have only do a single IUI. So we have a quantity of IUI is always 2 to 3 IUI, but do IUI once in a cycle. So single IUI is always good than the double IUI. And base time for after semen collection is 2 to 3 hours after the semen preparations will be there. So we are not waiting more. If you want to wait, then you have to put the semen sample in the incubator, CO2 incubator, unless and even you are doing timing within 2 hours, I think so there is no requirement of the incubator in the establishing of the IUI lab. And number of IUI attempts, I think so. Let's say check it out, the ASHRAE guidelines which was published, and it says 3 to 4 IUI, not more than that. 3 IUI, not 6 IUI, beyond 3 IUI. So 6 IUI not on gonadotropin, 6 IUI, then 3 IUI on clomiphene citrate, and 3 IUI on gonadotropin in a good prognosis patient. So good prognosis means the age between 25 to 30 years, the married life between 2 to 3 years, the endometrium is more than 8 mm, tubal factor is not involved, then yes, we can go ahead, and especially in the azoospermia when microtesa is not effective or patient is very poor. Now, what about the inseminating? I think so. We are always going to be transfer the total functional motile sperm count. And I will like to say that what type of preparation. So in normozoospermia, what type of our preparation will be quick, easy, and cost effective. So I'll say quick, easy, and cost effective in normozoospermia. You can have a BD syringe. First, you collect the semen, and then you collect the media, 0.5 ml, 0.5 ml, and you can just 45 degrees slant. There is no centrifugation is required. Whole sperm will be go inside the media, and you discard the semen and get the supernatant portion of the media and inject inside the cavity around 0.4 ml or 0.25 ml inside the cavity. So this is the no centrifugations. Nowadays, the novel technique is available, but what we can say something, no technique is having any advantage over. Only you can use when there is a more leukocyte and more debris, more infection than double density gradient method. Rest of the other condition, you can use swim up technique. So I will like to say that most of the time swim up, centrifugation, double density gradient method, it will be there is infection and debris, then the double density gradient method will be there. So microfluidic test, novel approach we are using, but still the data is not clear. Now, what about the insemination technique, non-touch technique, 0.25 ml, long cannula. I'm not touching the cervix with the 2 speculum or cusco speculum with the pan-shaped manner. I will introduce. If it is not going to go inside, then I will use a partially filled bladder. Even it is not, then I will go by the sonography. But why not sonography? As you are doing sonography under the in MTP, you are doing under sonography. Why not IUI under sonography? I will recommend it to all the learners that start IUI under sonography. It will not give disadvantage. It's all about the practice. It will make your learning curve more good. And later on, you cannot, sometimes if sonography is not available, your experience makes sense. So it's not about the debate. There is no pain in IUI until and even your preparation is wrong. Until and even your amount of semen you are loading inside is wrong. It's wrong. Until and even you are doing a wrong technique, that means you are catching the cervix. So you are so traumatic. So these are the 3 conditions where cramp will be there. I don't think so any antibiotic, any tranquilizers or any painkiller will be required. So I don't want to give anything inside in my IUI, post IUI. I don't find out any infections, and I will not give. It's all about your preparation technique, how people are doing preparation, and as well as luteal phase support. So yes, IUI, all meta-analysis which is say that luteal phase support as good as IVF. So 300 milligram BD, suppository dydrogesterone 10 milligram 1 TDS. This is what we can, or if you are interested in gel, then 1 OD, 8% gel, 1 OD will be there. So lastly, I can say, does some rest is matter? I think yes, in IUI, this is the publication, 10-minute rest is always there. So don't advise your patient that to go as all you are doing in IVF, but in IUI, yes, rest matters. So we are advising the patients for minimum 10 minutes, 15 minutes after the IUI. And this is what about the question which was asked by you. The question, and this is PICO questions with draft recommendations. I will just quickly within 5 minutes. What are the indication of IUI versus intercourse? So we say that is the Honor score. The total motile sperm count should be always more than 5 million. The younger patient, that is what we can say indications. Anovulatory, when is oral stimulation required? Then we can say something. It's In couple with unexplained infertility and total motile sperm count above 10 million, IUI combined with ovarian stimulation is to improve the live birth rate. What is the influence of sperm quality on IUI outcome? Can we define threshold levels? No threshold is so, but it's all about that at which threshold you are doing IUI. So at my clinic, if my post pre-wash count is less than 10 million, I will not do IUI in the era of IVF. I will limit my IUI. Yes, I will not do, but I will limit my IUI. I will explain that IUI success rate will lesser. What is the influence of sperm quality on IUI outcome? Can we define threshold? That already discussed. When is the base timing of insemination IUI? 36 to 40 hours after SCG. So that already we discussed. And what is the optimal number of insemination? I think the single IUI is always better than the double IUI. And last thing is there bed rest? This is the again that yes, bed rest is beneficial. The moderate evidence will be there. What is the ultimate number of consecutive IUI cycles? Then they says that the 3 IUI is recommended. 3 is that is insufficient, but 3 to 4 IUI. After that, I think so success rate will reduce. With semen preparation is still not known. I already discussed. And what is the cost effective of IUI versus IVF? I think so when there is a male factor prominent, I don't think so we should go for IUI rather than IVF. And how can you prevent multiple pregnancy? This is all about the strict cancellation criteria, low dose stimulations, HMG stimulations, which will always prevent your result of the multiple pregnancy. And this is the schematic diagram. See, that's why I'm saying that Honor score is more than 30. Then I will always go by the expected management. So what is Honor score? Practically, I will like to say that 25 to 30 years of the age, less than 3 years of the active married life, endometrium is good. Suppose the sperm count is always low normal or above normal. These are in primary infertility, less than 3 years, less than 2 years. Don't hurry. I've seen a lot of people are rushing toward, even after 1 year of married life, they are rushing toward IUI. Don't do IUI. Now, if there is expected management for 6 months, if there is no pregnancy, and if Honor score is between 30 to 40%, then you can do CC plus IUI, right? But if Honor score is more than 40%, then you can go by the gonadotrophin. But when your post-wash motile sperm count should be more than 5 million or pre-wash is more than 10 million, then I will do IUI. And if my IUI is failed 3 to 4 times, then yes, I will shift the patient for IVF in unexplained infertility. So this is what about the gonadotrophin is always better. This is the study. Any type of gonadotrophin. So don't say something FSH is better than the HMG. It is all about the whether you are which type of gonadotrophin. It's all about to stimulate. Your main aim is to have a 2 to 3 follicle by stimulating the ovary, nothing else. It will always increase genetic dilutions, decrease the genetic dilution, increase genetic efficiency, will give the better pregnancy outcome. Lastly, the progesterone luteal phase support ovulation induction. I already discussed that in CC-induced IUI cycle, it is no benefit. But if you have a gonadotrophin and CC plus gonadotrophin, it is always having a benefit. So use progesterone support just like IVF in gonadotrophin and CC plus gonadotrophin. Thank you so much. And I made my the centers, and where you can see something that how I proudly feeling that my presence in Patna, and how I proud to say that my chief consultant is Dr. Smriti Spurs is there, because she is trained here and she's already having a lot of experience. So I think so in a next series, we will be talking together something about the more about the luteal phase and aging and infertility. So thank you so much for giving me opportunity and giving your time. This is a lecture where I deliver all about my all experience and all about I find out all the physiology through the clinical practice. Thank you so much.
Thank you, sir. I'm sure we have collected many take-home messages. It was wonderful listening to you, especially in the concepts of IUI, sir. And lots will be benefit, and I'm sure many will continue and join us in our continued series. Thank you so much, sir.
Thank you.
Thank you, sir.
Okay, madam. I am doing it.